Hello, everyone. Welcome to another Monday virtual morning report. Really excited to be co-discussing with Mark today. I'm Youssef. I'm a hospitalist in Atlanta. Mark, do you want to introduce yourself?
Yeah, hey guys, I'm Mark. I'm a hospitalist in the Bay Area. Yusuf and I are finishing our first year as hospitalists, which is pretty crazy. And Yusuf, let's continue to make this a regular thing. This is two discussions in 1 week.
Yeah, absolutely. I'm excited. And then Austin has a case for us. We call Austin America's primary care doctor. Austin, do you want to say hi?
Oh gosh, I cannot stick. But yes, no, thanks so much for letting me present today. And yeah, I'm Austin. I'm a general internist, primary care doctor. And yeah, excited to present the case to you. So I will go ahead and give you the first aliquot. So this is a 22-year-old gentleman. He's coming to the emergency room with right leg swelling. And so, just a little bit of history that you could gather from the emergency room note was that he noticed the swelling like last night. There wasn't any trauma yesterday, but he did report a couple of weeks ago kind of slipping off his couch and landing onto his kind of flexed right knee. The leg feels a little warm to the touch and has been spasming, but there's been no fever or rash. And that's all you got. So I'll stop there.
Yeah, Mark, you want to give it the first shot?
Yeah, sure. Yusuf, this is something we see very commonly, I would say, in hospital medicine. Maybe not a 24-year-old. I feel like we usually see much older patients, but like unilateral leg swelling. I think like probably like 90 to 95% of these cases wind up being a DVT or cellulitis. So I feel like I'm going to put all my energy in the beginning of ruling out a blood clot and infection of the skin. And then Austin, when you say leg, is it like the whole right leg, like below the knee, or where exactly is it in the leg that's swollen?
Yeah, I'll be authentic and I'll kind of go through the time course. Basically, it's a little bit hard to tell at this point, but I'll later share that this person was seen in the emergency room like last night, and then the next day you see the patient in the clinic. So at this point, it just says right leg, generally speaking, but you don't really know much else beyond that.
Perfect. I love, yeah, we'll stay authentic to it. Yeah, yeah. If it's, right leg, usually people, when they say like right leg swelling, most commonly it's going to be swelling below the knee. And like I said, most commonly it's going to be a blood clot or cellulitis. So I'm going to put all my effort in that. It's pretty odd for, I would say, a 24-year-old to have a blood clot, but we do learn that there was some preceding trauma, which, is definitely this doesn't seem like a major trauma. It's not like this patient had a hip fracture from a traumatic injury and then got an operation. That's a high risk for a blood clot, but some minor trauma. So maybe there's a transient, minor risk factor there. But also it's a possible portal of entry for a bacterial infection too, cellulitis. And then anytime I think of like cellulitis, I always think of kind of like the no misdiagnoses of cellulitis, like, like a necrotizing skin and soft tissue infection. So we're going to want to do a very good, exam here and see how like systemically ill the patient is. But honestly, Eustace, like, I think without the exam and just hearing this from the emergency room, I'm just going to be kind of keeping those two diagnoses in mind. I wouldn't go too much further without really examining the patient and getting really specifically like where the swelling is. Because if the swelling is really like, knee swelling, then we're kind of, entering the land of like a monoarticular arthritis, or if it's maybe knee and ankle, then we're really, you know, uh, uh, dealing with like an arthritis syndrome. But yeah, what do you think, Yusuf?
Yeah, like you said, I think it's important to localize whether is it to the skin or is it to the joint. And I think the diagnoses you mentioned already are really good. So we mentioned potentially having like a DVT, a cellulitis. Other things to think of are things like venous stasis. You don't expect this right in a 22-year-old, but the older they get, and if it's bilateral, you more you want to think about venous stasis. And then popliteal cyst rupture can be like a very close mimic to all of these conditions because it's also can happen subsequent to trauma. So it would be interesting to do the exam and DV. Cellulitis has a very high rate of misdiagnosis. So almost like a quarter of all patients with cellulitis turn out not to have cellulitis in the end and turn out to have another diagnosis. So I'm just excited to do the exam and see what we think and take more history. Back to you, Austin.
All right, yeah, superb, excellent start. So the next talk, I'll just give you some past information because it's pretty rich. So the patient has a history of a traumatic spinal cord injury at the level of T6 about 3 years prior to his presentation. And he's wheelchair bound related to kind of lower extremity paralysis. And then he also experiences pretty significant spasticity of lower extremities, as well as neurogenic bowel and bladder. Otherwise, his medical history is notable for depression. Surgeries he's had none outside of the sort of spinal surgery around the time of his accident. Family, there's no known history. Socially, he lives with a family member who's not currently working or going to school. Health-related behaviors, there's no tobacco or alcohol use. He does smoke marijuana daily, but no other recreational substances. And the medications, he takes baclofen, gabapentin, naproxen, and oxybutynin. And I'll stop there for your reflections.
And I'm so sorry, Austin, I missed the first part. What was the past medical history?
Yes, so the patient has a traumatic spinal cord injury at the level of T6 that occurred about 3 years ago. And so he's wheelchair bound with lower extremity paralysis, has a spasticity in lower extremities, and then has neurogenic bowel and bladder, all related to the the spinal cord injury that he experienced.
Wow. And thank you so much for the additional rich history. And I think this complicates it because now we know the patient definitely has like a risk factor for clot. So you think of patient is not able to like walk around, and which is like a risk factor for developing a DVT. And then we don't see any like immune compromising medications when we heard that. So I think I'm still like anchoring on the fall. I'm wondering if like there was something after the fall. And like Mark said, I want to make sure there's no fracture and make sure it's where it's localized, whether it's to the joint, to the bone, or to the skin. What are you thinking, Mark?
Yeah, totally. I think, yeah, patients that have, and you said also lower extremity paralysis. Yeah. Yeah, patients with lower extremity paralysis too, in addition to the DVT, and we've mentioned cellulitis a few times, like especially when they get an injury, right? Because they don't have that sensation like in their lower extremities. They might have a wound, but they might not notice it and might not feel it originally, and then that could also make the wound, worse, right? So I see a lot of patients that have, unfortunately, like paraplegia and quadriplegia that have a lot of like pressure ulcers, right? And it's very common. It's kind of similar to patients with diabetes, right? Like they knock their toe and they get a wound, but because they have neuropathy and they don't really feel that wound, it can get worse and worse until they have a diabetic foot infection, osteomyelitis, and a terrible like skin and soft tissue infection. So we see that progression pretty frequently in patients with diabetes, but I do see that progression also in patients with paraplegia and quadriplegia as well. So these patients, you have to do a really, really good skin check, especially if they're coming in with very focal pain. Yeah, and this wouldn't really fit hyper acutely, but these patients do get a lot of just neuropathic pain in general. You can see these are very common medications that patients with paraplegia are on: gabapentin, baclofen. I think the medications are probably not related to the presenting syndrome. Like I love to blame baclofen and gabapentin on many things because they do have a lot of like neurotropic side effects, but probably not related to what's going on right now. But yeah, I definitely would want to do a really good exam on this patient. Yeah. Let us know more, Austin.
All right, perfect. Yeah, so the vitals, the patient was afebrile. The blood pressure was 103/62 with a pulse of 108. He was breathing 20 times per minute, setting 100% on room air. I had a VMI of 22. Also, the exam that's documented in the emergency room says that there's a edema of the right knee, and there was warmth and a small area of erythema of the knee. They did some basic labs like a CBC and a CMP. Those were normal. They did a lower extremity ultrasound to look for a DVT, as you mentioned, and there was no blood clot. And then they also did an X-ray of the right knee, which I will show you now, and then I'll give you guys the interpretation. Okay, can you see the X-ray?
And
Sorry,
not
can you
yet.
see it or no? Not yet. It says that I'm sharing my screen.
Oh, I see
Do
it.
you see it?
Yeah.
Oh, you see it. Okay.
You see it? You see
Okay.
it?
I do not. Kind of.
let me see if I can expand the image a little bit.
Yusuf, I think you should go to Austin stream, right? And
Yeah, I see it now.
Yusuf, this is not a chest X-ray or CT of the chest, so I feel very uncomfortable. I don't know about you.
Yeah, I don't think I look at enough normal X-rays of the knee to know like if the patella is within like normal range of an X-ray. I know there's nothing, no major fractures. That's all I could say. But other than that, I wouldn't know.
Does the tibia look a little degenerative? I don't know, like in the right film, almost it looks like I can't really use fancy radiological terms, but it almost looks a little degenerative. But would you say use of like joint spaces, like again, like us like not looking at these too often, like pretty normal to maybe mild narrowing, possibly?
Yeah,
And then like the lateral femur, like I guess the lateral like epicondyle looks also a little like I don't know, degenerative to me. But again, these are just I just don't look at these enough. I would need Austin's interpretation and then also the radiology interpretation.
Oh no, that was excellent. I'm definitely not too skilled with the X-rays of the knees either, but basically what it showed was that there was a small suprapatellar soft tissue effusion and then some soft tissue swelling that was nonspecific, but there was no sort of acute osseous abnormality. And then I agree with your interpretation of the bones. They didn't make explicit comment on that, but from what I've seen, it didn't stand out too much. It's probably just within the range of normal or something you might not be unexpected in someone that had a spinal cord injury. And so basically at this point, the patient was advised that he, possibly had some sort of like ligament or meniscal issue related to this trauma that happened. They gave him like a shot of methylpred and then sent him on his way, told him to follow up with a primary care doctor. And so he came to us the next day, but I'll pause here and see what reflections you guys have.
yeah. So interesting here. I think first of all is the heart rate. So his heart rate is very elevated at 108. I would be curious to see like what his baseline is and see if it's like much higher than baseline. Sometimes patients with if they have some form of denervation, they might have a higher heart rate, but I would be curious to see if that's different than prior. And it's interesting here is that like when we hear usually about like edema of the knee, we automatically assume that it is the joint. When in reality, it could be like many things. Like for example, it could be the joint itself. That's when we talk about arthritis or things like that. But then it could be if you have any ligament or tendon rupture, like the team assumed here, it can also cause like swelling around the knee. And then the third possibility is like a ruptured like cyst or around like a popliteal cyst around the knee that could cause fluid around it that could mimic this. What would you add, Mark?
Yeah, that's the same approach I use. I think when we see like a red swollen knee, we kind of jump right to arthritis and articular processes. But I always just try to step back, especially in someone that has trauma, and think about periarticular structures too, right? Like articular pathology usually needs an arthrocentesis, especially like acute monoarticular, arthritis, that being like mainly gout, pseudo gout, and septic arthritis. But then periarticular pathology usually needs an MRI. I mean, you can usually treat supportively in the beginning, but like to actually diagnose the pathology, unless you are great at the physical exam maneuvers like Austin is, I would definitely need an MRI to diagnose these periarticular pathologies. But Yusuf, what do you think? What is your pre-test probability for articular versus periarticular?
I think we can do all these like exam maneuvers. Like you can try to do like an anterior drawer test or a Lachman test and see if there's like laxity in any direction. But I think my highest pretest probability is in the history. So we hear somebody who had a fall, like a slip from a couch, and now has like worsening of the joint itself. So this history is making me think less of the joint, but I'm thinking more of either a ruptured cyst, number one, or a tendon or ligament rupture. And I think ultrasound here could potentially be helpful. I don't think I've ever looked at an ultrasound of like a cyst or Baker cyst to see how it is like to be ruptured, but I think that I would think of that. And then you could do like laxity exams in the clinic. What would you do, Mark?
Yeah, totally. I think, yeah, that's my, I definitely have a higher pretest probability for a ligament, tendon, bursa, those types of pathologies. The only thing I'll make note of is like, unless this patient has, an obvious like portal of entry that we think they could have like a contiguous like septic arthritis, right? Like they had the injury and then that caused a wound, and then they had kind of like translocation into the knee joint, and we are concerned they have septic arthritis. Like I definitely want to, check for like micromotion tenderness. It seems like this patient wasn't probably, I mean, it sounds like they got discharged to the emergency room. So maybe they didn't have too much tenderness when they manipulated the knee, but they're afebrile. You don't have to have a fever to have septic arthritis. Sometimes it could just be very localized, especially if it's a contiguous cause of septic arthritis, as opposed to like disseminated, like bacteremia disseminating to a joint. So that's the only thing I would make a note of, and probably a less probability for gout in a 22-year-old. I mean, trauma is definitely a mild risk factor for gout, but it's usually in someone that has a degenerative knee for many, many years. So it'd be very odd for a 22-year-old, especially unless they had some sort of genetic cause of hyperuricemia. So yeah, I totally agree with you, Youssef. Do you think they need a MRI? MRI their knee?
I think I would want a master ultrasound from Austin first, and then if we don't catch anything and it doesn't improve, then maybe.
Okay, I'm definitely not a master ultrasound of the MSK, but as far as like the focused field, that doing a Baker cyst ultrasound is actually pretty straightforward. Like just putting it on, and you can make a lot of progress pretty quickly. And then I did do a focus of the knee, but we'll get to that in just a second. But basically, the patient comes to the clinic the next day for follow up of the emergency room visit. You just confirm the history, and it seems like everything was as was stated or reported in the notes. Like he was putting on his shoes, he said, and then a couple days before, and then noticed that his right knee was swollen. He's been having worsening spasms and spasticity of the right lower extremity over the last couple of days. He tried some over the counter analgesics, just like NSAIDs, but it didn't really provide much relief. But he does say that sometimes he just like punches his legs when they spasm, and that seems to help. He's been doing that since basically his injury. And he doesn't recall like any swelling shortly after the fall. He really just noticed it over the last few days. We did ask some more history about his health-related behaviors, and he is sexually active. He doesn't use condoms consistently. The last time was like within the last few weeks. There's no penile discharge or a change in his baseline urinary habits, like he self-casts like 5 times per day. And then he's not had any animal exposure or travel. And then our physical exam, he's lying on the table and no acute distress. His abdominal and genital urinary exams were without some concerning findings. We didn't see any chancre or penile lesions, no penile discharge, no inguinal lymphadenopathy. Going to the leg, he did have some swelling of the right knee compared to the left, but it seemed to extend like proximally into his thigh, like mid thigh, I would say. There was some mild warmth, but there was no erythema or rash. There was good inguinal and dorsalis pedis pulses. He's paralyzed, so he's not able to, actively move the leg. He doesn't have any sensation in the extremities, but you do range of motion of the knee without any significant issues, though it did induce like a spasm in him. And then we just did a point-of-care ultrasound at the suprapatellar fossa just to look for any joint fluid in the joint, and we didn't see any significant effusion in the suprapatellar recess. So I'll pause there.
Do you want to go first, Mark? But you can't get an ID consult.
But she's so close. Awesome. Was there, did you, or on the X-ray, was there like enough fluid to do an arthrocentesis?
So on the X-ray, it's difficult to determine like the fluid amount. Typically, if it's detectable by X-ray, it suggests that there's maybe enough to do a tap, but sometimes you can get fooled with like soft tissue edema. So at least on the ultrasound that we did in the clinic, there definitely wasn't enough to safely tap, at least from my perspective, but it definitely wasn't prominent at all.
Gotcha. Yeah, the only reason I mention that is I have such a low threshold. Like I don't like to sit on effusions in general. They're really in most body cavities, right? That being a knee effusion, especially an acute effusion, like, unilateral pleural effusion. Obviously that, could be, parapneumonic but like I just feel like I see a lot of effusions that are sat on and then wind up to be some sort of sinister pathologies. I've seen a bunch of cases of that in the past, and it just makes me have a low threshold to tap, especially given like an arthrocentesis is a pretty low risk procedure. But it sounds like Austin did an excellent ultrasound and there's not much fluid to tap. I guess I'll just touch on the kind of sexual history that Austin gathered, which is great. I'm just kind of thinking of the overlap between sexually transmitted infections and arthritis, right? I think the first thing we all think about is disseminated gonorrhea, gonococcal infection. Classically presents as like an oligoarticular arthritis with like tenosynovitis and a rash, but it can present as monoarthritis as well. So that's important to keep in mind. It's definitely not as common as oligoarticular arthritis, but it can present as monoarthritis. So that's kind of like the main one to consider. Like any, HIV can present in many which ways. I think arthritis is definitely not as common as a presentation as arthralgias. But I think, HIV can do whatever it wants. And then any opportunistic infection in a patient with HIV can certainly cause arthritis as well. Hep B is another one to think about with like serum sickness as well. And then syphilis as well, usually in like secondary syphilis, can present as arthritis as well. I would say monoarthritis also not as common, but those are kind of and then there's this whole category of reactive arthritis, right? So someone has a sexually transmitted infection, a few weeks to a month prior, and then has this more, again, oligoarticular arthritis syndrome. But, just like anything else in medicine, the patient has one knee that's red hot and swollen now, but maybe 2 days from now, they'll have a wrist or an ankle or, a hip that's swollen. So that's kind of how I overlay infections and arthritis. I'll ask Athur if I missed anything, but Youssef, yeah, what are your thoughts?
Yeah, I think now that you're focused on the organisms, maybe I'll try to focus on testing. So, for example, let's start with gonorrhea and chlamydia. Gonorrhea and chlamydia can cause like arthritis, or they can cause a reactive arthritis as well. So it could be the organism itself and the joint, or it's causing your body to like have an autoimmune-like reaction. And a lot of these patients who get these syndromes have a genetic predisposition of seronegative arthritis that then they develop them. And you could either try to get with gonorrhea and chlamydia, you can try to culture it from the joint itself, so you can get a PCR, or you can get it from other sites wherever the patient is sexually active, whether like rectal, oral, or in urine. So you can get samples from all sites. That's for one. Second one we mentioned was HIV. So HIV antigen antibody test results positive within 12 days of exposure. Maybe in the future we'll get better tests, but depending on the timing of the exposure, you might consider getting either an antigen antibody or a PCR. So this is like a board question, basically. If it's before 12 days, then you want to consider getting the PCR. If it's after 12 days, then you want to consider getting the antigen antibody. And then there is syphilis. Different institutions test differently. So some institutions start with like an RPR, which is non-specific, while other institutions start with a VDRL, which is more specific. And you can go through either pathway. The RPR usually wanes with age, and usually you use it as a test of cure. So if you get it and it's positive, and then you treat someone, then within like 6 months to 1 year, you expect it to go down fourfold. Other organisms that Mark mentioned, I think common bacterial organisms, we would have to it's less on my differential, even how less severe this is. Mark, what are you thinking of the erythema that goes like more proximally? Do you think this is like a tenosynovitis, or do you think this is like just an arthritis or like a cellulitis?
Yeah, that was a great overview, Yusuf. That was awesome. Athur kept giving me like a thumbs up while you were talking, so that was great. Yeah, I guess I would have to know how superior like the erythema goes. Like, is it just a little bit, above the knee, and this is just kind of like just an extension of the erythema? Or,
Let me just clarify. There
yeah,
really
yeah.
wasn't much erythema, just like some swelling and some warmth. There really wasn't much erythema.
Okay. And then Austin, did it go like midway up the thigh, or was it just like a little bit up the thigh? Or...
Yeah, I would say it extended like just approximately like maybe like a quarter way up the thigh from above the knee. So it didn't extend like all the way to the inguinal area or anything like that. But it wasn't there was noticeable swelling like more proximal to the knee.
Gotcha. Yeah, Yusuf, I'm kind of just thinking about what the origin of this was, right? Is it some sort of like, myositis? Not saying like autoimmune myositis, but just kind of using that word in a very, general term, like inflammation of the muscle that tracked down to like below, like inferiorly based on the injury, or is it like inflammation of the articular or periarticular structures that move superiorly? So that's kind of, I guess, unclear right now. It kind of prompted me to think about, especially in a patient with a history of paraplegia, is like CPRS too, like complex regional pain syndrome, which can happen after trauma. And I think patients that have like prior trauma as well and a history of like a history like this are at increased risk of this. And it can cause a whole host of like local like reactions. Like you can have autonomic, you can have different temperature sensations, swelling, warmth. So that's something that just pops in my mind, especially given this like swelling is kind of odd, I would say, especially given the presentation. But yeah, what are you thinking, Yusuf?
Yeah, I think that's a tough diagnosis. I think usually you want to like rule out the common things, and then it's classically described as erythema, pain, tenderness that's like out of proportion to your exam. And a lot of times these patients will get like courses of antibiotics slash treatment and testing, and then after everything is negative, the provider feels like more confident making that diagnosis. I think that's pretty reasonable here. I think with the sexual history, I think it's low hanging fruit to rule out like every single like sexually transmitted infection because it's like indicated in this age group. Uh, and then if everything is negative, I think that then my next on my schema would be CPRS potentially.
Oh, okay, so yeah, there's someone coming to my house to do some repairs, so I will be shutting off like on and off. So I apologize that they arrived a little bit late. But basically, yeah, no, just as you said, the etiology at the time was kind of unclear. So I wrote in my note that sort of the main decision tree was to figure out if this represented inflammatory monoarthritis or not. But based off the POCUS, without a significant effusion, it sort of made it less likely. But as you said, it was low hanging fruit. So I wanted to investigate that. The other thing of concern was just with this patient and sort of the limitations on the exam things that we would typically look for. We're always concerned about is there deeper pathology. So basically, what we did was we ordered the STI testing, some more labs, and then also ordered CT of the right lower extremity. And then basically totally gave him some emergency room precautions, and then just gave him some some higher dose of baclofen to try to help with his symptoms. So basically, as before, we did a CMP was normal. We got a CBC, and it showed like a mild anemia to 12.2, and the only baseline we have from was like 3 years ago, and it showed a hemoglobin of 14.7. So the hemoglobin was slightly down from before. The white count was 8 with a normal differential. We got a CK, which was 200, and the upper limit of normal in our lab is 171. We got an INR and PTT, those were normal. An ESR was normal at 9, but a CRP was a 54.4 with normal less than 8. We got a UA, which was no signs of inflammation, no blood, no RBCs. And then HIV testing was negative. Treponema antibody, that's kind of the algorithm we use at this institution, was negative. And then the urine gonorrhea chlamydia was also negative. So I'll pause there to get your thoughts.
Yeah, and Austin, how many aliquots do we have left?
There's 2 short ones left, and then I'll reveal the diagnosis. I kind of kept up and brief to give little nubs of information, just kind of how it happened in real life.
Okay, okay. And do you think this is a good spot to do like small breakout rooms?
Oh yeah, I think after the next alpha would be a good um, time to do breakout rooms.
Okay, okay, sounds good. So I think I'm glad all the workup so far is negative. All the infectious exposures, which would put like the HIV is negative, so you worry less about like an immune compromising condition, which is good. Uh, I think I still have an issue defining the problem because I think if we're calling it a monoarticular arthritis, then the differential is slightly different than we're calling it a possible like tendonitis of around the joint. You know what I mean? So if this is a monoarticular arthritis, then you have to like open the differential broader. But I'm not sure that is necessarily what I want to call it. Where's your head at, Mark, or what are you calling the problem at this?
No, I'm struggling to define it as well, and that's what I was going to ask Austin. Just a couple of follow-up questions. So when the swelling at superior was there pain like when you palpated like superior to the knee, like that's kind of area of swelling on the thigh? Was there?
Yeah, unfortunately, with the patient's like sensory deficits, you don't really elicit pain. It did like cause him, when I ranged the motion of the knee, it did cause him to like spasm there, and that was uncomfortable for him. And then because he'd been spasming more, he'd been, hitting his leg as I mentioned, and so he did have like one area of ecchymosis more proximally, but that was probably unrelated to the clinical presentation. But it was difficult to answer the idea of pain. He did report sort of the increased kind of spasticity and maybe neuropathic nature of his sort of general symptoms, but it was hard to definitively say there was like pain per se.
Gotcha. Yeah. Yeah, no, Yusuf, I'm still struggling. Like, is this like an arthritis focal myositis syndrome, which is like totally odd, with like the thigh involvement? I'm just kind of thinking of like the no misdiagnoses first, right? I think that like an infectious, like you mentioned, like an infectious cause of like arthritis or myositis seems probably less likely, right? We have like, I mean, the CRP is quite discordant with the ESR. Maybe that's just like the kinetics of it, right? Like the CRP rises faster than the ESR, so maybe the ESR is going to be high in a week or so. So there is definitely some inflammation, but the patient doesn't seem toxic, right? They're not febrile. They don't look too, unwell. So like a deep space infection, I totally agree with the CT scan, but I feel like my pretest probability is pretty low, but definitely wouldn't want to rule out like a deeper space infection for sure. And then I'm just thinking of like focal causes also of like myositis, like with that focal, like, I don't know why I'm like really like zooming in on the thigh swelling, just because I feel like it's pretty like atypical. Like there's things like diabetic myonecrosis that's not this patient, but can present kind of similarly with like focal areas of swelling and pain that patients with uncontrolled diabetes get. Compartment syndrome is a no misdiagnosis, but it sounds like that's usually pretty obvious on like exam. And then also the CK is only mildly elevated. Patients with like, I actually just had a patient with paraplegia that had paraplegia the other day and had a lot of spasticity, and a CK was ordered and it was like 4 or 500, which was consistent with the patient's prior CK. So a lot of times patients like this that have a lot of spasticity, they generate like a little bit of CK at baseline. So I wouldn't be surprised if this is this patient's baseline like CK, if that's, that just they spill a little bit of CK from the spasticity. But yeah, I think, Yusuf, I think we'll be able to make more progress probably on the CT, really defining exactly what is kind of going on in that knee and that thigh. And then I feel like we'll be able to make more progress there.
Yeah, I agree. And if you overlap, like what are the causes of like focal myositis? Like you mentioned, diabetes is a really good one. The other things like very rare, like parasitic organisms that can like cause this, but usually it's more pronounced and you have like other findings elsewhere. So I think the diagnosis of CPRS is still potentially there, and I want to know if the joint is affected and to see if to open that schema or not. So back to you, Austin.
Yeah, and the last thing I'll just say to Austin's point too is like, maybe given this patient has, given their paraplegia, like you probably can't assess for micromotion tenderness too well, right? Maybe if this patient didn't have like paraplegia, like they would be like jumping off the table if you move their knee a little bit, and this is like a slam dunk case of like, septic arthritis. And again, the swelling above the knee is still odd, but like I think we have to keep that in mind too. And but again, like also mentioned, like there's not a huge effusion, so there's a little disconnect there. But I just wanted to mention that the patient has like altered pain, perception.
Yeah, so you're feeling sort of the same tensions that we had in real life when the resident was like presenting me this patient. So basically, these labs were done like over the coming days. The patient was seen in the clinic like 4 days later, and the swelling had significantly improved. They got a repeat CRP, and it was all the way down to 5.9, so it had normalized. And then due to various logistical and social reasons, the CT had not been done yet, but during the visit, we were able to get it scheduled. And it's going to happen 2 days later. So that'll be the next aliquot. But I just want to get your general thoughts about, what you make of this kind of course that the patient experienced over the last 4 days.
I think number one, like I'm reassured. I think that's pretty good that okay, we're not missing like a large bacterial septic arthritis here. We're thinking this is something that was transient, and the question is why was it transient? Is it due to the nature of the infection? So, for example, if you're having reactive arthritis, could the patient just have like intermittent arthritis, just like worsens for a little bit and then improves later on, which is like just the course of the disease. So that's one. Or two is, did we do something to fix it? And I don't think we did anything like particular. We didn't give like antibiotics. Which is the right call, and we didn't like do anything else to like improve it. So I'm between those two. What are you thinking, Mark?
Yeah, totally. I think that definitely takes acute bad bacterial infections off the table. They just don't get better on their own typically, and maybe that puts more weight towards like like you mentioned, like diseases that flare, like intermittent diseases, like something like CPRS, right? And then I guess also sometimes like periarticular like injuries kind of can go through their like waxing and waning, right? Like I think a lot of times breaks, when you break your leg or something like that kind of is persistent until you fix it. But someone has like a tendon issue or a ligament issue or yeah, like those type of issues, they can wax and wane. So yeah, I feel confident that some of the really no miss scary diagnoses are probably less likely now.
Okay, very good. So the next aliquot will be the CT scan. So I guess if you want to do breakout rooms, I would just have everyone get together and say, what do you think the CT scan is going to show? How does that sound?
Oh wait, Austin, can I ask one more thing? Maybe if you mentioned this, but did the exam change? I know he felt better, like the inflammatory, but did the exam, was it the same as the previous exam?
I didn't examine him the second time because I wasn't in the clinic, but from what was documented, it seemed like the swelling of concern had improved. But I can't say definitively because I didn't examine him.
Okay, I'm gonna share the poll results for the votes. I think we have like most people think the CT is gonna be normal with a quarter thinking maybe myositis, maybe an effusion, and then for final diagnosis, a half of the group thinks it's maybe reactive arthritis. Maybe we'll find like a gonorrhea from a different site. Half the group thinks it's complex regional pain syndrome, and maybe a small percentage think it's myositis. Mark, any final thoughts you had?
No, I don't think I'll be able to make any more progress until the CT scan, to be honest. I feel like I really need the CT scan to define the problem, personally.
Yeah, I agree. So I think this is thank you, Austin, for bringing this case. Like this is how real life is. Like you don't get like quick answers, and a lot of times there's a lot of uncertainty. So Austin, what happened next?
Okay, I shared my screen. Can you see my screen, the CT scan?
Oh no, Austin's making us interpret a knee X-ray and now a
I will
CT.
give you the interpretation, but I'm going to play the CT scan. Okay, here we go.
Yeah, we can see it.
That's definitely the femur.
Crushing it.
Patella.
Okay, so I'll pause because the main sort of finding is more proximally. So I'll play it one more time.
And if anybody has any guesses, feel free to put them in the chat as well.
No, I do joke around, but thank you, Austin, for like actually bringing the images. I'm trying to get better at like all forms of radiology because I just realized that like we may not all practice in places that have easy access to radiology, our radiologists. So I think it's important to try to get as best as possible at radiology. So this is great.
Okay, any thoughts?
I'm winging it, but I wasn't sure if there was something inside like the medulla and the proximal bone, but I'm not sure.
Isn't the medulla in the brain, Youssef?
You're right. You're right.
No, very good. So yeah, I will just reveal what the read was, okay, and then I'll point something out to you. So basically, the read was there's normal anatomic alignment, there's normal bone mineralization, there's no acute fracture or dislocation, there's no joint effusion, but there's a non-specific curvilinear, peripherally enhancing fluid collection in the deep aspect of the anterior compartment of the thigh, that's sort of horseshoe shaped. And it's sitting on top of the vastus intermedius, which sits between the rectus femoris and the vastus medialis. And it measures about 3 to 4 centimeters anterior to posterior, 1 to 1.5 centimeters transversely, and then about at least 20 centimeters cranial-caudally. In fact, they couldn't actually see it to completion. So here, if we go back from the beginning, so if you look, it's pretty subtle, but if you pause right here, do you see this sort of hypo density compared to the rest of the muscle? And you can see it a little bit on this view as well. That is what you're referring to. As you can see, it extended approximately all the way. You can still see it a little bit here. You can still see it. And then it starts to go away, like right about there. So that's what the CT showed. Any final thoughts before I reveal the final diagnosis?
Yeah, I guess I'm just curious, like, is this an incidental finding? I mean, it's hard to believe that it would be, but the reason I mentioned that, it sounds like it extends so cranial, like so superiorly, and the patient only has swelling a little bit above their knee. So that's interesting. Like, Austin, was there like a more pronounced, like, did it correlate with the exam? Like, was there a more pronounced swelling where like that fluid cavity was more pronounced? Like, was there a correlation or?
You know, I can't say there was a prominent correlation, but if you think about where this fluid collection sits, it sits below the main muscle of your quadriceps. So the rectus femoris, it sits on top. And so it's actually sitting below sort of the main muscle that you can see from the outside. So it's, I can't say there was prominence, but I guess I'd point your attention to the idea that it's peripherally enhancing.
Yeah. Anytime I hear the word peripherally enhancing, I don't know, for me, infection always kind of jumps out a little bit, and inflammatory causes. I guess just stepping back, when I see like fluid, just like where it's not supposed to be, especially like focally, like I think the big two things we want to rule out is a bleed, and then also an infection. And then obviously once we rule out those two things, there's also sterile fluid collections as well. And I'm just wondering that, like, also, Yusuf, like, is it possible that this patient had a bursa that burst? But this seems very organized, I guess. So like, I would just think if there was like for instance, we talked about like a popliteal cyst rupture, but this is not, not what it is. But if it bursts, like, could there be fluid seeping through the thigh? But this seems very organized. So yeah, I've never seen something like this before, Yusuf, but I would want it to rule out bleed, which patient doesn't have prominent risk factors for besides the trauma. They're not anticoagulation or antiplatelets and doesn't have like a coagulopathy, and then also infection. But like an infection transversing like that, I don't know. I feel like the patient would be more ill. But yeah, what do you think?
Yeah, similar to you. I don't think I've seen this before, but like you said, like big categories like blood, pus, or water. So is this a bleed or is this large abscess? Doesn't sound like it, and it's definitely like possible. But I think bleeding is more common. But I wonder if we would have seen something on exam as well. And then infection is like maybe the trauma could have been like a nidus for them to come in, and then sterile fluid is also likely of like maybe there was like a bursa or like a bursitis with this fluid. So Mark, how would you rank like most likely to least likely? How would you rank these three?
Yeah, and I'm just kind of playing the exercise too, of like what, I don't think infection is likely, but what this would probably, again, like, does this correlate to the patient's acute symptoms? But like, what infections can make someone not ill, but be that expansive, like in their thigh, right? Like, I feel like there's to be more atypical fungal, mycobacterial, parasitic. You mentioned parasitic infections previously. But I feel like just the size of it just doesn't match the hyperacute syndrome. And there's also a disconnect between how well the patient appears. And also it got better. Like the symptoms got better without any intervention, which is interesting.
Yeah,
I
I agree.
I feel like that makes me think sterile being the highest, to be honest. Yeah.
Yeah, I think so. Maybe like a bursitis type of thing, and then
Yeah.
and maybe bleed less likely, and maybe in large pus maybe less likely. Anybody has any thoughts in the chat, please feel free to share with us. And Austin, we're really excited to learn.
Okay, yeah, no, you guys did incredible, and sort of the same thing. And I think this is a working diagnosis. I can't say for sure, but um, based off the findings, the radiologist read it as non-specific peripherally enhancing fluid collection in the deep aspect of the anterior compartment of the right thigh, favored to represent hematoma over abscess. So what I think happened was, and you guys spoke to it, there seems to be a disconnect between the timing of when the patient presented and then sort of the findings that we saw. It'd be difficult to explain how you could get such an expansile lesion in such a short amount of time. And then there's the peripheral enhancement, which for hematomas, from my reading, usually take on the order of a week or weeks in order to develop. So probably this represented a hematoma that occurred like at the timing of his fall, and then for whatever reason, and there's some social circumstances with the patient, but probably led to a delay in presentation. And I think also speaks to how things just continue to progress and get better without any dedicated intervention. So how I was piecing this together was like a combination of like NSAID use, which the patient was using like not excessive, but a fair amount of NSAIDs, plus spasticity, which there are case reports of people having prominent spasticity, actually developing bleeds or muscle injury related to that. And then sort of altered tissue mechanics related to having a spinal cord injury, just like atrophy of the muscle and the sort of disuse of the tissue in general. And then the patient sort of like traumatizing their leg repeatedly, that all of these things together led to this deep bleed. And then again, given the peripherally enhancing nature, probably this had been going on for some time. And then we were just seeing sort of like the progression and the resolution. But entered the course of the illness, like somewhere between, which made like defining what the problem was and the time course was very challenging. So I have to say this case was very humbling. So as the patient came to the clinic and the resident was having, he was like, oh gosh, this is like monoarticular arthritis. Like we got to figure this out right now. We go into the room. I'm like, it doesn't really seem like arthritis that we're solving. I don't know what it is. So just as you said, we need to find the problem better, but make sure we exclude the things that need to be treated right now. So got the labs done. And even tried to arrange like to empirically treat for gonorrhea, like just in case we needed to, because the peripheral testing isn't perfect, but given sort of the trajectory of how things went, some of it sort of just, unfortunately the patient improved like on their own. And then we got the CT scan, which revealed this. And so I'm not sure exactly how to interpret all of this, but that's how I was piecing it together. And I think it was just an interesting case of how it sort of started and how we were thinking about different structures. But in the end, I think in a patient that cannot, I think when we think about defining a problem, we're always relying on the history and the patient. But if the patient's ability to provide the history that we have our illness script for is modified, and it becomes very challenging to define the problem, like much more than before. And so I think this is where you have to, your threshold to order these tests is much different. So I have to say, before I joined the CT software, I don't think I would ever have thought to like order a CT scan in this scenario. But I think it was very helpful in sort of highlighting, how subtle some deep findings can be in a patient when they can't explain to you what happened. So that's how I was piecing it together. It's not perfect. So I'd love anyone else's reflections on what this might be, but curious case nonetheless.
No, I think it's a really, really great case, Austin. I think this is like how real life is. Like the tension exists even like at the end of the case. There's not always like one slam dunk. I think hematoma makes the most sense. And I think the resolution was a good test of like, oh, the patient is getting better with no intervention. So yeah, thank you so much for bringing this case. Any reflections, Mark?
Yeah, no, thanks for sharing. I'm just thinking about the CRP is also interesting. I mean, we know that blood is inflammatory and like, a hematoma is actually on the list of like a fever of unknown origin. And I've seen multiple times like, patients with hematomas have neutrophilic leukocytosis, mild fever. So I wonder if also the mild CRP elevation that went down was just this hematoma, just getting better. But that was just something I found thought was interesting too. But yeah, no, thank you for sharing. I feel like we talked about a lot of things in the session, so it was fun to think about.
Yeah, thank you so much. Simon, did you want to do the teaching points?
Yeah, absolutely. And thank you so much, Austin, for sharing such an interesting case. And I just loved the discussion, Mark and Youssef. It was so extensive, and we talked about all the structures. So we began here with a person with right leg swelling, and then we were thinking about vascular causes as well as muscles, bone, tendons, and we talk about the causes of infective arthritis such as HIV, syphilis, chlamydia, gonorrhea, and we discussed complex regional pain syndrome, which can cause pain, neuropathic symptoms, and some neurovascular structures. And then we were thinking as the patient was having intermittent symptoms, so we were thinking about anything that can wax and wane, and the diagnosis of hematoma was made. And it was a great learning experience. And
Thank you so much, Simon. Thank you so much, Austin, for the great teaching case. So hope you all have a wonderful day.